Assalamu alaikum and welcome to this recorded lecture on gynecological emergencies. During this lecture, we want to understand the presentation of gynecological emergencies, discuss investigation of gynecological emergencies, and look at management of not pregnancy-related gynecological emergencies. So we look at gynecological emergencies in general at first, and we want to understand what are they? What are the gynecological emergencies I'm talking about? Please take a few seconds to write them down. You can stop the video, use a pen and paper to write them down. They are mainly ectopic pregnancy, adnexal torsion, tubo-ovarian abscesses, hemorrhagic ovarian cysts, gynecological hemorrhage, and vulvovaginal trauma. What is the common presentation of gynecological emergencies? They are generally presented by abnormal vaginal bleeding, so either unscheduled vaginal bleeding, meaning not cyclical or non-cyclical vaginal bleeding, or heavy vaginal bleeding, and this can present with or without acute abdominal pain. Let us look at this case study first. Mrs. R is a 27-year-old woman who's seen with worsening unilateral pelvic pain over the past 24 hours. She's 7 weeks from her last menstrual period and has used contraception inconsistently. During the physical examination, she complains of right iliac fossa tenderness with mild rebound tenderness on the same side. Bimanual exam reveals a right-sided 4 to 5 centimeter tender cystic mass and a 7 weeks size uterus. So speculum examination is not recorded here and should have been done also, but is essentially normal. And the bimanual examination, which means digital PV examination, reveals a 4 to 5 tender cystic mass. What is the diagnosis here, or what is the possible diagnosis of this case, just with this information? So, I put to you a question. Is her presentation most consistent with ruptured ectopic pregnancy, adnexal torsion, ovarian hemorrhage, ovarian cyst, or all of the above? Yes, you would be right in saying all of the above. With this information only, you cannot make a proper decision yet. The basic rule in gynecological emergencies is that all vaginal bleeding is due to pregnancy and all pelvic pain is due to ectopic pregnancy. So until proven otherwise, as long as you do not know differently, all of abnormal bleeding is due, or vaginal bleeding is due to pregnancy, and all pelvic pain is also due to ectopic pregnancy. So most diagnoses can be made by a history, a physical examination, beta HCG testing, and transvaginal ultrasound scan. So, What can be the possible differential diagnosis from this previous case that we've looked at? We've already looked at some of the possible diagnosis, but there's other differential diagnosis. It could be an infection, so acute salpingitis, tuber ovarian abscess. It could be complication of pregnancy, such as ectopic pregnancy, septic abortion, postpartum or post-abortion endometritis, post-medical abortion sepsis. Adnexal accidents can be common, such as ovarian torsion, ovarian rupture, ovarian hemorrhage. And we've mentioned some of those in our list of differential diagnosis already. Other gynecological problems have to be remembered, such as flare-up of symptoms from endometriosis, or some people always mention ovulation or Mittelschmerz, but this is really a myth that this should not be given as a proper a differential diagnosis for pelvic pain, because Mittelschmerz causing or ovulation causing Mittelschmerz or problems in is really a myth and should not be given as a differential diagnosis. Non-gynecological causes can be mentioned, such as appendicitis or appendiceal abscess, inflammatory bowel disease, irritable bowel syndrome. Urinary tract problems can be seen as differential diagnosis of as possible differential diagnosis, such as acute cystitis or pyelonephritis or ureteral stones. Finally, orthopedic problems can be seen as differential diagnosis, such as lumbosacral spasms or lumbar disc prolapses or disease. So there's a large number of differential diagnoses for this patient, Mrs. R, and her presentation. And we want, first of all, to kind of see what can we do to make this a bit more specific, her presentation. And of course, there are several investigations that you can do. So the pregnancy test is negative. The hemoglobin is 11.2. The white cell count is 13.5, and the platelets are 321. And the TVS, of course, is important. And here you can see a slightly swollen adnex. Here, this is the adnex, the right adnex. It's slightly swollen, and it has got a lot of blood flow around the adnex. But there's no significant blood flow visible within the adnexal mass. So you can see that there's a lot of there's a lot of blood flow around the adnex, and you can see that the adnex gets a lot of there's a lot of collateral blood supply to the adnex. This presentation is supposed to represent an adnexal torsion. Adnexal torsions are 3% of all gynecological emergencies, so not so many actually. They are due to twisting of the ovarian mass on the pedicles, so the adnex twists on its pedicles, which are the utero-ovarian ligament and infundibulopelvic ligament. And this is an involvement of tube or ovaries, or usually both. And as subsequently edema develops, when the venous blood flow outflow is blocked, but the arterial flow towards the adnex is still working, because the venous blood flow gets blocked first, and only with very much down the line of this emergency does the arterial blood flow also stop or get disrupted. So ischemia only develops once arterial inflow is also blocked, but this does not happen until very much down the line of this emergency. So the presentation is sometimes after recent physical activity. You have a unilateral pelvic pain, as in this patient. Physical findings are not that reliable. You sometimes have nausea, vomiting. You have usually or often increased white blood cell count, like in this case. You have some peritoneal signs, as in this case, and you might even have fever, but not in this case. The pain is often intense initially, and then it might improve a little bit. And the exam shows a unilateral tender adnexal mass, as also seen in this case. Adnexal torsion evaluation is difficult. The ultrasound scan, you can see this picture, as I shown to you before. What is important in this picture is that you have a somewhat larger or increased size adnex, but you also have a cyst. In order to have an adnexal torsion, you do need a cyst. The cyst is needed because otherwise there would not be a torsion. The cyst is what gives the momentum to the ovary to twist. Without a cyst, you do not have a momentum for the ovary to twist, and the ovary won't twist. Okay, so usually you have a cyst, and you have a somewhat swollen, adnex with a lot of increased blood flow around. But as you can see, neither CT nor MRI nor color Doppler ultrasound flow studies are 100% diagnostic techniques. So, a patient like that, what would be the management for this patient? Just think about it a minute. It is important to minimize the time of diagnosis from diagnosis to treatment in order to have the largest chance for a healthy ovary after treatment. The diagnostic laparoscopy is the best method to confirm and also treat adnexal torsion. So during diagnostic laparoscopy, you can unwind or detort the adnex, and also you can remove any cysts that you find to prevent retorsion, so recurrence if necessary. So this is a picture of a laparoscopy, two pictures of adnexal torsion. On the left, you can see the torted ovary very well, and you can untort it easily, but you have to remember to remove a cyst that you find so that it doesn't retort. And the same on the right picture. Okay, so let us go to the next case study. Here we have a 22-year-old patient who presents with sudden onset of pain in the left iliac fossa about 2 hours ago. Now the pain is across her pelvis. There's no vomiting and no diarrhea. She's not bleeding and she has no discharge. She does not use contraception. She's not sexually active. Her last menstrual period was 16 days ago and she has a regular cycle. The only thing in her past medical history, current and past medical history, is really a history of a right oophorectomy for a serous tumor, a serous ovarian tumor. So, what do you have to do next? Examination. So in the examination, it is very important to check her vital signs in all emergencies. This is very important, and you can see they are normal in her case. Then you do an abdominal examination, and which shows some tenderness across her lower abdomen. This is worst in the left iliac fossa. You find some local guarding over the area of maximum tenderness, but there's no rebound tenderness at all. The speculum examination is normal, and during the internal examination, you find some tenderness in the left adnix and a palpable fullness also in the left adnix. So, what is the diagnosis in this case? This is an ovarian cyst hemorrhage. There's also other differential diagnosis. It could also be an adnexal torsion. It could also be an ovarian cyst hemorrhage, but an ovarian cyst rupture. But because it started, in this case, it started 2 hours ago and is getting worse and worse and worse. This is most likely to be an ovarian cyst hemorrhage. But how can you, what investigations do you have to do for this patient? You have to do a transvaginal ultrasound scan. You have to also do full blood count, and you might want to do a CRP to exclude infection, because also PID could present like that, and tubo-ovarian cyst could present in equal way and could even have a similar ultrasound picture. This is a picture of a hemorrhagic ovarian cyst. You can see a cyst, which could be a simple cyst, but it's not simple, because you see a simple cyst would be complete black, but this cyst shows some hyperechoic material, and this represents blood. So what's the management of an ovarian cyst hemorrhage? It is usually self-limiting. So you admit the patient for observation and serial full blood counts to make sure the hemoglobin doesn't drop. If the diagnosis remains unclear, if the hemoglobin is dropping, if she doesn't improve, if you're somehow uneasy about a patient with presenting with kind of severe pain, you have to do a diagnostic laparoscopy, because that usually gives you the answer and kind of clarifies the situation. So an ovarian cyst hemorrhage would be obvious on a laparoscopy. The next patient is a 19-year-old patient who has been unwell for 5 days with recurring fever, pain in her right pelvis, nausea, loss of appetite, and she's vomited 2 hours ago. She's a nulligravid patient who takes the combined oral contraceptive pill regularly, and her last menstrual period was 3 weeks ago. On examination, her right iliac fossa, there's tenderness in her right iliac fossa, but there's no rebound tenderness. Speculum examination reveals an odorous green discharge from her cervix. There's tenderness during the vaginal examination, and there's also a fullness in the right side, and there's definite cervical excitation. What is the diagnosis? I think you can make the diagnosis from this patient. What is her diagnosis? Her diagnosis is, of course, a pelvic inflammatory disease. This is what you suspect. You have to do swabs, you have to do full blood count and CRP, urinalysis, and also an ultrasound scan has to be done. But a laparoscopy will only be necessary if she does not respond to the treatment. So the ultrasound scan, the transvaginal ultrasound scan, shows these pictures, which represent bilateral pyosalpinx. So usually the tube is not visible on the ultrasound scan, but here you can see the tube in a kind of large and enlarged, and you see some If it was a hydrosalpinx, this tube would be black, but there's some echogenic materials within the tube which kind of you suspect is a pyosalpinx. So what is the management of tubo-ovarian abscess or tubo-ovarian or pyosalpinx? What is the management? Yes, the management is IV antibiotic treatment with a broad spectrum antibiotic covering chlamydia, gonorrhea, and anaerobes. This is usually cefotaxime or ceftriaxone, doxycycline, metronidazole. It could also be azithromycin and metronidazole, but it has to be a combination treatment, and it should follow the local guidelines for this treatment. So you give this treatment for 24-48 hours and see what happens. Most tubo-ovarian abscesses resolve with appropriate treatment and management, but some do not improve. And then if there's no improvement within 72 hours, it is important to do a laparoscopy to get some materials from the site of the infection. Sometimes it is even necessary to do an oophorectomy or salpingo-oophorectomy to remove the focus of the infection. But often it is it's enough to take some culture materials from it to get a proper bacterial culture, so that it is possible to target the antibiotic, the bacteria causing the infection appropriately. Okay, let us go to the next case, which is a 54-year-old patient who presents with heavy, profuse vaginal bleeding. She usually has an irregular cycle with periods every 2 to 3 months, but once her period comes, it's prolonged and heavy and very difficult to manage for her. She's a widow and not sexually active. She has some crampy lower abdominal pain, but no discharge, no nausea, diarrhea, or vomiting. Her cervical smears have always been normal, and the last one was done 2 years ago. She has a past menstrual history of hypertension and diabetes, and in the obstetric history she has 5 normal vaginal deliveries. What do you do next for this patient? Absolutely, you have to do an examination and you have to take the vital signs. This patient presents with severe acute bleeding, and the vital signs are very important. It's very important in this patient to stabilize her. I hear you always say you stabilize the patient if a patient just comes with pain. So then stabilization is not really the issue. The issue is to treat her pain or to investigate the reason for her pain. But in this patient, actually stabilization is important. So you do the observation and you find her blood pressure is 125/85, heart rate is 104, and she's apyrexial. What do you notice in these observations? Right, you notice a tachycardia. So therefore, the bleeding already takes a toll on her cardiovascular system. You note that her blood pressure is actually normal, but remember that usually she suffers from hypertension, so maybe this is low for her. Her abdomen is soft and non-tender, and the uterus is not palpable. On the speculum examination, you also see heavy bleeding with clots. And on the VE, her uterus appears large with no adnexal masses, but the cervix, vulva, and vagina are otherwise normal. What is the differential diagnosis? And you have a number of differential diagnoses here. It could be perimenopausal bleeding, it could be uterine fibroids, it could be pregnancy related. I know she says she has not had intercourse and she's a widow, but this has to be in the back of your mind as well as a possibility, and you have to just exclude that with a test. Very important. It could be an endometrial cancer, or it could be a sarcoma, because in this age group, older women, sarcomas are rare, but when they occur, this is more commonly in the older women, so this is a possibility. Or it could be cervical cancer, but the normal smears and the normal outlook of the cervix are probably making this a very unlikely possibility. Investigations need to be done, and these include swabs. urinary tract pregnancy test, full blood count, group and safe, and CRP. UNE is important because you do not want her renal function to be compromised, and also ultrasound scan is important. So when you now think about this being perimenopausal bleeding, how do you manage perimenopausal bleeding? Perimenopausal bleeding is managed with high-dose progesterones to stabilize in acute situations. Sometimes you can consider GnRH analoga, which are given on as an implant, a subdermal implant, which then kind of releases the agent over a long time. So you give one subdermal implant and this stays in place and works for 1 month. After a month, they have to have a new subdermal implant. And this releases GnRH in a constant manner. And by release of GnRH analoga in a constant manner, you do suppress the release of FSH and LH, and you kind of make a premature menopause. You cause this woman to be in a premature menopause. She is 54. Maybe this would be a good way of treating her because menopause is imminent in this patient, and maybe she has a little bit earlier menopause. This would not matter too much, so maybe this is one way of treatment for her. Surgery would include hysterectomy. This might be necessary, especially if no other option works. Endometrial ablation would be a good option for this patient. Endometrial ablation includes the insertion of usually a hot balloon, or usually a balloon that is then inflated with hot fluid, sometimes also a microwave, kind of a device that uses microwave for endometrial ablation. And then with this kind of hot thermal effect or microwave effect, you burn away some of the endometrium. Endometrial ablation does not usually lead to amenorrhea, but it reduces bleeding substantially and can be a way of managing this patient. Finally, a Mirena IUS is also possible. This is an intrauterine device that has levonorgestrel in its stem, and it releases levonorgestrel on a daily basis, a little bit, a small amount, and over time, by this progesterone release, thins out the endometrium. And by thinning the endometrium, the bleeding gets less or even stops with time. So Mirena IUS causes amenorrhea with time, and the patient has to be aware of this. So you will now ask me, what is the best treatment? What should we give to the patient? This has to be discussed with the patient. To stabilize her at first, she needs high-dose progesterone to stop the bleeding initially. But then for longer-term treatment, you have to discuss with her and see what she prefers, what sort of treatment is that she would kind of feel most comfortable with. And you can also, of course, it depends on what is available in your kind of healthcare setting. So endometrial ablation, you need this treatment, you need these kind of devices that give the that to make the microwave or hot thermal ablation. So you can only offer that if you have that available in your healthcare setting. So in summary, but the important thing is in this patient that you have to decide together with the patient what is the best treatment for her. So in summary, gynecological emergencies are common. They present mostly with abnormal vaginal bleeding or abdominal pain, or a combination of both of these symptoms. An ectopic pregnancy must always be excluded, and they can mostly be assessed with the help of taking a good history, examination, urinary pregnancy test, and simple investigations such as full blood count, CRP, and transvaginal ultrasound scans. Thank you very much for listening. If you have any questions, please write them down, and we can discuss them together once we have our online discussion sessions. Thank you, and I hope to kind of be able to answer all of your questions then.